Hello everyone, I'm Richard Conway reporting for Room Now from EULAR 2022. The meeting is in Copenhagen. I'm attending virtually, so I'm coming at you from Dublin, Ireland today. I'm here to talk to you about oral presentation presented on Friday at the meeting. This was OP0263. The title of this presentation, which I'm going to take quite a bit of issue with, as you'll see, is the favourable balance of benefit and harm from long-term low-dose prednisolone added to standard treatment in rheumatoid arthritis patients aged 65 plus. This was by Boers et al. The study is overall called GLORIA, and we'll call it that from now on. This was a double-blind randomized control trial. As the title suggests, it was in rheumatoid arthritis patients who were 65 years and older. These patients were on background therapy, and at entry to the study, they needed adjustment of their therapy. What did that mean? That meant that their disease wasn't fully controlled, and the baseline DAS in this study was a mean DAS of 4.5 going in. So that's quite a high DAS. That's in the moderate disease activity category. Now, interesting to me, only 14% of these patients were on biologics at baseline. So with this active disease. And what the authors did, they randomized them in this pragmatic control design to prednisolone 5 milligrams daily for 2 years or to placebo, and it was double-blind randomized control trial. They enrolled 450 patients. Interestingly, there was quite a high dropout rate, so a dropout rate of 40%, which was matched between the two groups, but not insubstantial loss to follow-up. Over the course of the study, the DAS28 decreased by 0.37 points. So that's not nothing. It's also not an enormous amount, and it's slightly hard to interpret how clinically relevant that actually is, how much of a benefit that was to patients. There was less joint damage, but that was by 1.2 points on the SHARP score, which is really nothing of clinical importance. And the trade-off for this was that there was a 24% increased risk in adverse events in the prednisolone group, with a number needed to harm of 9.5, and mostly this was infection. So, as I said, I take quite a bit of issue with saying that this is a favourable balance of benefit and harm with low-dose prednisolone. I think there's a couple of issues here. The first one is this improvement in DAS worthwhile at all? Not so sure about that. Is it worthwhile in terms of what the consequences are in terms of infectious risk? I don't really think so. And the other thing is that we are not in a situation with these patients, only 14% of whom are on biologics, where it's prednisolone or nothing. There are many other options that these patients could be given that we can utilize in these patients. And all of those have repeatedly been shown to be safer than steroids in terms of infection risk, cardiovascular risk, and in every other way. So all of our biologic drugs are safer than steroids. I think in this patient group, we shouldn't be talking about whether we give them low-dose prednisolone or not. We should be talking about whether we give them a biologic or change their biologic. That's the route we should be taking rather than using a drug which has been shown repeatedly to have increased harms above other agents. For more from EULAR 2022, please tune into Room Now across our platforms and follow me on Twitter at Richard PA Conway.